So the first question, which of the following is a pathognomic sign of a long bone fracture? Okay. All these will be there when the fracture is there. Pain on the moment, yes, definitely it will be there. Swelling is going to be there. Deformity is going to be there. But what is the pathognomic sign? The sign for a fracture is abnormal mobility. The answer for this question is abnormal mobility. Let us discuss a few important one-liners. Trust me, my class is not going to have a lot of one-liners or mnemonics. It's not what you guys need. What you guys need is concepts. Okay. So, the most common pathognomic sign for a fracture is abnormal mobility. The most common symptom is going to be pain. The most common sign is going to be swelling. Okay. Let's have a few discussion regarding the fracture and the questions which can come from that. Okay. What is a fracture? A fracture is a break in the continuity of the cortex and the medullary cavity. Don't miss out on that. Okay. Based on the classification, what I have divided that into the, depending on the intensity of the trauma, how we can classify fractures and why, because many questions are coming from this. Okay. So just stay with me. Okay. So based on the type of trauma, if you take the trauma to be a significant one, okay, what do you mean by significant is the led to high velocity injury. Okay. If it is a significant trauma, you get the typical fracture patterns. What are all the typical fracture patterns? The transverse type, oblique type, spiral type, all these are the typical fracture patterns. If the force or the trauma is insignificant, okay, then there are two possibilities. Okay. If the insignificant force is occurring on a normal bone on a repeated manner, you get something that is called as a stress fracture. If the insignificant force is occurring on an abnormal bone, you get a pathological fracture. Why this mechanism is important? Because just with the clues in the question, you will be able to differentiate between a pathological fracture or a stress fracture and directly arrive at the answer. All right. If for what are the examples for an abnormal bone? It could be an infective disease bone, a bone tumor might be there, or a metabolic bone disease could be there. All these are examples of an abnormal bone. All right. So, like I discussed before, what are all the injury patterns based on a significant trauma? All right. First one is a transverse fracture that occurs due to a tensile force. An oblique fracture that can occur because of a compression force. An oblique fracture can get displaced when there is a shear force. All right. A spiral fracture can occur when you have a twisting force, or when the force is like direct heavy force, you get something called as a comminuted fracture. All right. Okay. Next question, guys. A 25-year-old male is playing football with his friends and lands on an outstretched arm. He is seen in the emergency department and radiographs are obtained in the figure A. He is taken to the operation theatre for open reduction, internal fixation, and post-op imaging is given. Which is true in regard to the fixation achieved? All right, a simple question, but the options I have made it difficult for you guys. Okay, the fracture is what? A transverse type. What have they done? They have done a plating with screws. Okay. Now the question they're trying to reach, what kind of fixation we have achieved or what kind of healing we are trying to achieve. Relies on enchondral ossification. The fracture size stain is 2 to 10%. Soft callus is eventually covered to hard callus or occurs via Haversian remodeling. Okay. They're asking about bone healing. All right. The bone healing, the answer for this question is primary bone healing and the answer is Haversian remodeling. Now let us discuss a few points about the bone healing so that you will know how to tackle such questions. All right. All right. If you look at the fracture healing, there are two types. Okay. Primary fracture healing or the secondary one. The primary fracture healing, what you guys have to understand that there is going to be direct bone to bone contact and no callus is going to be there and there are going to be no micro movements. This will be achieved when you're trying to fix the bone using absolute stability. Typical example for an absolute stability device is plates and screws. Okay, so for that question, I guess you'll understand the concept now. We are using plates and screws. There is no gap between the fracture site. We have given absolute stability. So the answer is primary healing via Haversian remodel. Okay, if you look at secondary healing, there is going to be callus formation. There is going to be micro movements at the fracture site, and the how we do it using IMIL nailing, which in turn will provide a relative stability. All right, guys. So what I want you guys to understand here is, see, for the same fracture I say, they're using plates and screws, no gap in the fracture site, so primary. Whereas, if I have used a IMIL nail or a K-wire, there will be some amount of gap with bridging callus. In that case, you go for secondary healing. All right. So that's how we differentiate between absolute stability and relative stability. All right. Both will unite the bone, okay, but it is very important to choose like which type of fracture to be fixed with what stability. That is not required, but what is required is for you guys to identify the fixation correctly. All right, look at this question also. A 45-year-old man presents with a femur fracture following a road traffic accident. All right, after 6 weeks of conservative management, x-ray shows the following finding. What stage of fracture healing is the patient in? Okay, the answer for this question is the reparative phase. Now let us discuss a few points regarding fracture healing. Okay, see guys, here I want you guys to understand that just like any other tissues in the body, the bone also has the potential to repair itself. Okay, the body continuously tries to repair all the organs. Similarly, the bone also is able to repair. But the reparative phase or the healing phase of the bone takes place over a wide duration of time. And based on that, they ask you a lot of questions. All right, so just stay with me. I've tried to simplify it as much as possible. All right, if you divide the stages, and to easy remembrance, I have kept it as 2 to 2. Okay, 2 to 3 days would be the hematoma formation or the inflammatory phase. That is predominantly dominated by platelets and neutrophils. So in the question, usually they ask which is the first type of cells to occur in the inflammatory phase. Don't put it as neutrophils, rather platelets becomes the first and then comes the neutrophils. Okay, from 2 to 3 weeks up till 2 to 3 months, you can put it like even up to 6 months, you can put it like the reparative phase. Okay, there will be neutrophils will be present and macrophages are going to be present. Beyond 2 to 3 years or more than 3 years is when you're going to have the remodeling phase. When it has entered the remodeling, these acute inflammatory cells are going to come down and chronic inflammatory cells, for example, T and B lymphocytes are going to predominate. Okay, this is very important. And the first stage of union in the X-ray, we'll be able to see the callus, that is actually the soft callus, at around 3 weeks. Okay, I hope now you would have been able to understand why this is reparative phase, okay, and not an inflammatory phase. The inflammatory phase predominantly in the first 2 to 3 weeks. Beyond that is the reparative phase. Okay, yes. Let's look at this question. The figure A in the radiograph of a 52-year-old male who underwent open reduction internal fixation of a both bone forearm fracture 9 months prior. He complains of persistent pain at the ulna fracture site. His C-reactive protein and erythrocyte sedimentation rate are within normal limits. What is the most appropriate definitive treatment? Now look here, based on the knowledge, let's say they have tried to use plates. That means they have tried to achieve absolute stability. In that case, there should not be any gap between the fracture and no callus. Okay, this is what we know. But here, even after 9 months, there is a gap at the fracture site. That means there is some problem regarding bone union. For this 9 months is a very important terminology. Okay, just like any other specialty or any other field for that factor, we always feel when we do things in the right intention, we expect the results also to come to us in the right way. But life is never like that. Okay, there are several external factors or internal factors that is going to affect the result, right? Just like your preparation phase. Here also, Even though the doctor has tried to achieve absolute stability by using a proper plates and screws, because of some reason, it could be the patient could have given weight much earlier or any other reason, there has somehow occurred a gap. Okay, and if the gap is not uniting for 9 months, that is the golden period up to which we can wait and watch. We call it as a non-union. All right. So in this case, what we have to do, this is an example for an atrophic type of non-union where there is no potential for newborn formation even after 9 months. So we'll have to do a revision plate fixation, open reduction tunnel fixation with a bone graft. What is this bone graft going to do? Bone graft is going to give that new bone, is going to give that extra push. All right. So that is what is required. So next question, similar to non-union. Which of the following substance is used for bone formation in patients with non-union? Here, substances, what we have to understand is certain substances has bone supporting capacity. So only certain substances has bone induction capacity. A simple cement all will be a bone supporting device. So something that has bone inductive property is a bone morphogenic proteins or BMPs. So the answer for this question is bone morphogenic proteins. So let's have few discussion regarding a bone union. Okay. So up till 6 months, we have termed it as a delayed union. If only after 9 months there's not going to be any callus formation or any signs of union or signs of non-union, we are going to give the term as non-union. The most common bone that suffers from non-union is tibia. The most common site is diaphysis. What are the types of non-union? It could be hypertrophic, oligotrophic, or atrophic. Why this is important is because how we are going to manage them. The management differs for these types of non-union. What we have to understand regarding this hypertrophic non-union is that, as the name implies, there's going to be lot of callus. So what does that callus indicate? It indicates that the bone is able to form. Okay, we are having this bone induction, but the thing is it is not happening in the correct place. So for that, we'll have to only focus on this inadequate fixation. So you'll have to fix it with better stability because good biology is there. Whereas in atrophic non-union, what you see is the biology itself is very poor. So there is no bone induction there. So along with fixing with better stability, you will have to provide something with that extra push to give that new bone formation. So that is called as bone grafting. That could be BMPs, our iliac crest bone graft. So all this will give the new bone formation. Okay. All right. So one more question is there on this union. So let's solve this. A 50-year-old male with a history of smoking presents 8 months, all right, after a tibial fracture. X-ray finding is given below. What is the most likely diagnosis? Non-union. Now you will be even be able to say what type of non-union. So there is no callus at all. So it is mostly atrophic type of non-union. So see, once you know the concept behind that, solving the questions becomes simple. All right, next question. An elderly woman is brought to the OPD after she slipped and fell from her chair. She is known case of breast cancer with distant metastasis. The X-ray of the patient is given below. Which of the following statement is false? False. Okay. It occurs in abdominal bones. Okay. Previously, when I discussed an insignificant trauma, so just slip and fell from chair. Insignificant trauma on an abnormal bone. All right. It's a case of breast cancer is given. I already told tumor bones are example for abnormal bones. In that case, what do you expect? A pathological fracture. So the type of fracture here is a pathological fracture. So which of the statement is false? So it occurs in abnormal bones. This is true. Mirror score is used to assess the risk of fracture. Yes, for pathological or tumor based fractures, we always use mirror score. The PET scan is the gold standard evaluating in bone metastasis. Yes. Pain only occurs after the fracture. So this is the false statement. In pathological fracture, you will have to know that pain occurs before the fracture. It gives the warning. That means the bone is getting weaker and weaker and weaker, so that even on normal loading, you start getting pain. All right? Yeah. So regarding pathological fracture, how we discussed before, an insignificant trauma is occurring on an abnormal bone. Example is tumor, infection and metabolic bone diseases. The most common clinical feature is pain before the fracture. Investigation, first line of investigation is always the simpler ones, that is the X-ray, but you have to proceed with an MRI. But the gold standard for any pathological fracture is a biopsy. Most common location for a pathological fracture, if it's an osteoporosis, metabolic bone diseases, point dominates over hip. If it is a metastasis, the hip dominates over spine. That is proximal femur more than the spine. All right. Now let us solve this question. A young marathon runner is participating in a marathon competition. After running for about 100 meters, he develops pain at the anteromedial aspect of tibia, which was mild to start with but increased on further running. X-ray was abnormal. Here let's solve. The trauma, he's getting pain. So some insignificant trauma is there. Why? Because running again and again. So repeated on a normal bone. There is no signs of pathology. So doctor ordered a bone scan. What is the likely diagnosis? So where is the pain? It develops on the tibia. In the tibia, the stress fractures on the tibia are named as shin splints. Okay, so the answer for this question is a stress fracture of tibia called as shin splint. Look at another similar question. A 30-year-old marathon runner presents with pain in his shin after increasing training intensity. X-ray finding is given below. What type of fracture? It is a stress fracture. All right. See, based on the concept of stress fracture, they have given two different questions. All right. So see, this fracture, even one more clue you can have is it will usually be an incomplete. Incomplete, I mean, is the entire cortex to cortex length will not be affected. Okay. It will usually start at one side of the cortex, the other will be normal, and it will go here. This will be intact or not broken. So in such cases, you can undoubtedly go for stress fractures. Okay. Few words about stress fractures. Repeated, in the question, these should be there. Repeated insignificant trauma on a normal bone. It's also known as a fatigue fracture. The most common bone again is tibia. The most common bone in the foot is second metatarsal neck, which is known as March fracture, more than the third metatarsal. Investigation is the first line is always an X-ray followed by MRI, which becomes a gold standard here. The management is usually a conservative management is enough. This is an example for a stress fracture or a March fracture. Okay. Next question. Which of the following bone cells is responsible for secreting the bone matrix? Let's discuss, since a lot of questions in INI-CET is based on the histology, I thought to give you guys a brief things about histology so that you are able to recognize the cells. Okay. If they give this kind of a picture, always remember guys, osteoclasts are, giant cells, giant cells. They are the macrophages, they eat the bones. Okay. So these giant looking cells are basically the osteoclasts. They are responsible for bone remodeling, characterized by increased TRAP. The cells which are on the borders of the bone forming cells are the osteoblasts. They are characterized by increase in ALP. When these osteoblasts have used all their energy, they become old. They settle down in the matrix like forming osteocytes. They are the spent osteoblasts. So the answer for this question is responsible for bone secretion is osteoblast. Okay. This is another histology picture to differentiate between a fully formed mature lamellar bone or an woven bone. See here, the entire bone, this pink color is fully formed. Here there are numerous gaps. Okay, that signifies if it's an immature bone or a mature bone or a simply to put as a well organized bone. All right. Now coming to the important things, management of trauma. Okay, based on these, every year you get one or two questions. Two basic concepts you'll have to understand. Okay, what do you do with a isolated monotrauma or if it is a polytrauma? In polytrauma, is the patient stable or unstable? If you get this concept correct, you will never go wrong in the questions. So I have given plenty of questions because every year this concept is tested to make you guys thorough with the concept of polytrauma and monotrauma. Okay, play close attention. Okay. In the management of trauma, the patient has arrived in casualty. As usual, for all trauma patients, you follow the ATLS guidelines. That is A, B, C, D, E you have. A is you check the airway, B is breathing, C circulation, and then you go for disability. In the disability is where you come to ortho. I am isolating this for orthopedic discussions. Okay. If it's an isolated ortho trauma or if it's a polytrauma. First, let's look about isolated ortho trauma. Which bone is affected? What is the deformity? And what is the neurovascular status? To find out about this, you're going to send for investigations. It could be X-ray, CT or MRI as and when required. If it is a case of polytrauma, if it is an unstable one, you will have to remember the concept of damage control orthopedics. What is damage control orthopedics is you don't try to fix everything at the one go because there is a high risk of ARDS. Already the patient has numerous injuries. In that case, if you try to fix the bone, always remember guys, a surgery is again an injury causing an injury to the bone. So already the body is undergoing so much of injury, so all the inflammatory markers will be at full force. So again, when you take up the patient for surgery causing new injury, the body will not be able to handle it. Okay. So that is why they have come up with a terminology called as damage control orthopedics. Earlier it was ECO, earliest complete orthopedic care, but now they have changed it to DCO. Okay, damage control orthopedics. I'll tell you, how do you define a polytrauma? When the injury severity score is greater than 40, if there is no thoracic injury, if the injury severity score is greater than 20, but a thoracic injury is present. The GCS is less than 8, hypothermia less than 25 degrees, abdominal chest trauma or bilateral femur fractures. In that case, for 2 to 5 days, you will have this acute inflammatory products. Till then, only life-threatening injuries has to be handled. If the orthopedics injury is there, you can go with an X-fix or a temporary stabilization. Only after the patient has become stable, you are going to go ahead with a definitive fixation. Okay. So, what are the definitive fixation timelines is 7 to 10 days for pelvis and tibia. Till then, you're going to keep an X-fix and then only convert to nail and plates. Up to 3 weeks, you can wait for a femur on an X-fix. Okay. If the same is a polytrauma occurring for an open fracture, the golden hour is 6 hours. But one keyword which you have to remember is the 6 hours is for preventing infection. Okay. But for definitive fixation, you can go up to 72 hours. Okay. So the first procedure would be to debride within 6 hours, use a negative suction for the wounds and put him on an X-fix. And after the patient becomes stable, you can take it up for definitive fixation and soft tissue cover. This is a clear example of using X-fix, vacuum dressing for a open wound, and once it is all healed, you can take it up for a definitive fixation. That's how stage procedures you do. Okay. So, what is the common classification we use for open fractures? It is going to be the Gustello-Anderson fracture classification. And based on this Gustello-Anderson itself, you will be getting a lot of questions. So, the easiest way to remember Gustello-Anderson is based on the wound size. Okay. Type 1 is wound is less than 1 centimeter. Type 2, the wound is 1 to 10 centimeter. Type 3, the wound is greater than 10 centimeter. In type 3 only, there are differences like A, B and C subclassification. C is very simple. If there is a neurovascular injury, you put it as C. That becomes the highest priority. How to differentiate between A and B is slightly tricky. Both are about 10. But if the contamination is very much higher without a neurovascular injury, you put it under type B, or in the other case, you put it under type A. Okay. The most common bone to undergo an open fracture is tibia. The most common complication after an open fracture is going to be infection.